We have a few minutes for discussion. Peter, let me ask you a question. So where do you see the use, in your case, you had an acceptable angiographic outcome, but you weren't sure whether the patient was going to heal or not. There are devices that can tell you about tissue perfusion at the local level. Where do you see the use of those, like the SPY or HyperMed or Spectral MD, anything like that? Do you see something like that being useful?
Absolutely. So fantastic question, and I agree with a lot of people that I think the opportunity to really understand tissue perfusion really is kind of the golden goose and what we're looking for. There's limitations in skin perfusion pressure and TCPO2s for performance ranging from temperature of the room to who the operator is in terms of reproducibility. There's actually the next generation of these devices coming down the line based on kind of laser photometrics to be able to deliver us everything from a repeatable result, not dependent on operator, up to and including what I really can't wait for, which is the opportunity to measure perfusion at the time of the procedure. So I cannot wait for that day. You know, in the meantime, with the available technologies currently, I don't think anything yet outweighs kind of clinical close monitoring. So much of it is also just dependent on what our wound care doctors are doing on these CLI patients. And so I haven't yet reached a point where based on a SPP or a TCPO2, I'll say, you know what, we have to go back this week. But I also wouldn't say the SPP looks good, the wound's not healing, I'm done. But I think that might very well change in the very near future.
Ramon, can you add anything to that? Something you're doing differently?
No, I'd echo those comments. I mean, there are some interesting technologies in the pipeline. The Lumi microsensors are an interesting version of that technology. Most of the others do suffer from issues around ambient temperature in the operating theatre and whatnot. But maybe a sideline question might be around, we were admiring the result you had there, but there was a lot of dissection, you know, and I reckon maybe 70 or 80% of those cases will occlude, so we'll be technically unsuccessful. What would be great to have as a tool in our toolbox would be something to know which ones are going to occlude and which ones aren't, because I wouldn't know looking at that, and you had a great result, but hey, it could have gone the other way, right?
1,000%, you know, and it was a lot of the complexities of the patient and the previous procedures and the dissection planes that we created and other people created, where we stood there for a long time trying to decide what would be the best option in that situation. We did prolonged balloon inflations. As you saw at one point, we were probably shifting a dissection flap over the perineal as opposed to over the AT. We worried about making things worse rather than making things better. I'd be curious if on that case, do you think you would have done something different at the investment procedure, or would you have held off in monitoring?
Well, I probably would have stented it, you know, certainly through that popliteal segment. If I saw a mobile flap at the bifurcation, I probably would have done a bifurcation stenting procedure then. But I'm not saying that with any authority or knowledge on the subject, just I have a low threshold for stenting. And that's why I think we're in desperate need of a tool that helps make that decision-making process.
Absolutely. And, you know, again, it's purely qualitative rather than quantitative. You know, that distal P3 segment dissection almost looked like it was spiraling down into the TP trunk. And the concern was that if we deployed a permanent scaffold there, it would permanently shut down one of those territories. With regards to bifurcation stenting and the trifurcation, obviously, you know, your guess is as good as mine. With regards to long-term data for stenting below knee, it's not there. We were hoping for 3 months of patency, and the question was, if it went down, having a good kind of inline TIMI-3 quote-unquote flow result, the thought was we can kind of monitor clinically and bring her back immediately if we needed to, and I would rather not have the 2 layers of bifurcating stent in that territory if I did bring her back.
Yeah, you know, these are all good discussions. I think he highlights the fact that it's very challenging. You know, I mean, we talk about 1 vessel runoff, 2 vessel runoff, 3 vessel runoff. We talk, I mean, in that case, to be honest with you, I think the peroneal was probably more important than the AT. So I think there's a lot of complexity in these cases. The one question I want to ask Dr. Ida is, Dr. Mena showed us the ultrasound-guided pedal access. In your experience, how many of these do you need to do to be proficient at getting retrograde access for CLI?
I think it's depending on the case severity. If a patient with wound infection, a large amount of the ulcer, these patients should be treated with the bidirectional approach. So, but a patient with minor tissue loss on the less pain, just antegrade approach is good enough for achieving the good enough initial success.
How about you, Nick? You know, in your experience, I think it's clear that if you want to be a serious CLI operator, you need to have skills to do retrograde access. What do you think is the learning curve for these? Because sometimes when you're just starting, if you have a bad luck and your first 2, 3 don't go well, you may just say, forget about it, you know? So what do you think is needed?
Yeah, we were just talking about this. You know, if you're a vein operator and you do a lot of superficial vein access, you know, this becomes almost second nature. I mean, you don't have to have much of a learning curve. It's very, very quick, and you can learn that within the first few cases. If you're not a vein operator, I would say probably 10 to 15 cases needed to get you up to speed.
One question I wanted to ask, and Tony, please, you can comment too. Maybe we can start with you. In his case, Peter showed that, you know, he has not crossed the lesion completely, but he decided to do angioplasty. Same thing, Dr. Jonas, who is, by the way, he was a fellow last year. He won, so he's the fellow to faculty awardee. So I want to congratulate him for winning last year. He showed that in that case, they angioplasty first. They were able to see a little bit more. And in the coronaries, this is not uncommon for the CTO operators nowadays to balloon and then kind of gain the territory and move forward. Is this safe? Because I was taught when I was a fellow that you cross first, then you start doing angioplasty.
That's a great question, man. I think the thing is that it really depends on your level of comfort. So if you know that you're intraluminal to the point where additional flow will help you with the distal and you intend to finish, then I think that angioplasty is perfectly fine. On the other hand, if you're in a completely unfamiliar location and the wire loop has gotten huge and you're way out and you don't really know where you are, and that's your bailout to figure out where you are, I would really strongly advise against it. Yeah.
As the person that did it, I 100% agree. You know, so we crossed in that situation with a Viance microcatheter, kind of designed to stay intraluminal if it could, or at least to stay as close to luminal as possible with the dissection plane. Also, just kind of the feel of crossing gave you the sense of a CTO that then traveled straight in line without a knuckle, and the opportunity to try and elucidate what was going on distal in the vessel, knowing how many dissection planes were there previously, is why we kind of crossed our fingers and went with it at that situation. Certainly wouldn't be characteristic first-line approach.
Hey, Ramon, in one of the cases, they showed that they use a Viance, they use a crossing device. What are your experiences with crossing devices? Do you think they're necessary, and what are your thoughts on that?
I think we've heard a little bit already about retrograde crossing techniques, and we're going to hear more of it in the session. I must say, since we adopted those maybe 7, 8, 9 years ago, we use almost no re-entry devices now. So they have very little place in our practice. And I think some of those figures you showed there from Cleveland and that study you published in JEVT shows that if you master the retrograde techniques, you can have close to 100% technical success. And that would be, I think, something I've observed in most institutions that I've visited or worked in.
Usama, do you use re-entry devices, or are you using retrograde access instead of using re-entry devices? It's a little bit cheaper, I think.
I love a retrograde approach because re-entry device is a little bit complex and expensive.